Hello, everyone, and welcome to the Demonstrating Implementation Excellence stream at SNOMED City Expo 2025. So we have half an hour left before the networking session, but please hang on here and listen to this excellent presentation that we have for you. I want to raise thanks to IQVIA for sponsoring this stream. My name is Anne Hoyen. I'm the Implementation Support Specialist at SNOMED International, and I'll be your moderator for this session. All questions will be addressed at the end of the presentation, and for our online audience, please use the Q&A button to submit your questions to the presenter. And for those attending in person, please feel free to use the microphone provided in the room when the time comes. So now it's my pleasure to introduce Henna, Hybinette, and Mahreen Marghoob from Karolinska University Hospital, who will be presenting regional standard and terminology binding for tubes, drains, catheters, and fluid balance, a unified framework for medical practice and communication. So Henna and Mahreen, over to you.
Oh, yes. Hi everyone, Henna Haapa Hybinette. I am a health informatician and a registered nurse at Karolinska University Hospital, and my colleague.
Hello everybody. My name is Mahreen, and I'm also working as a health informatician at Karolinska University Hospital, but I work as a dental surgeon before that.
And we will be presenting as our regional standard. Before that, if any of you listened to my colleagues before, you might have heard this already. We work at Karolinska University Hospital, which is one of Europe's largest university hospitals, with about 15,000 in staff and 1,300 plus beds. We are affiliated with Karolinska Institute, which is on the other side of the road, and we have a lot in collaboration in research and education. And we are ranked number 5 worldwide by Newsweek. And this, let's see. So what we have done, this is not just a Karolinska initiative. This was done by all of the large hospitals that are owned by the region. So we have 7 large hospitals, also primary care is involved. As well as a region of Gotland, which is a small island just outside Stockholm. And together we have a shared EHR at this moment. We are procuring a new one. But at the moment we have about 700 caregivers using the same EHR system. We have about 53,000 users and approximately 130,000 patient notations are done every day. And I think we have about 2 million patient records in the system today. There has been a procurement of new health information systems. We have one for the patient data management system for intensive care, anesthesiology, post-operative care, and neonatal care. We have one for obstetrics as well, which is currently being configured. And we will have a new main EHR system within a few years at least in use. So this is something that we have wanted to do because we saw the need to standardize the information in the EHR that we use today, but also to prepare us for the future so that we can send this information between our systems. So this is what we have done. These are the tubes, drains, and catheters that we have standardized. It's a lot, I know. And the ones with number 1 at the end are central venous catheters, different kinds of central venous accesses that have actually been worked on the national level as well. But we had done our regional standard before they started their work. So we have been working together with them on the national level as well. So it is everything about arterial and venous catheters. We have urinary catheters, stomas, drains of different kinds that we have been working on. And all of this is based on national guidelines and international guidelines. As I mentioned, I'm a registered nurse. So this was my work in my previous life. And as you can see, it's just an illustration of the complexity that we deal with in everyday care as a clinicians. So if we think about fluid balance, for example, we have at least 5 pumps in this picture that you need to go in to calculating the fluid balance of the baby. And probably, I don't know exactly this one, but probably quite a few of these tubes and drains that we need to take care of and know how they are affecting the patient. So it's a very complex area. And not just a complex area, but it is also something that our patients, they come and go. They are in different care settings. They can be in primary care. They can have, for example, a urinary catheter at home, or they can have a central venous catheter that is inserted that they go home with. That needs to be taken care of, that needs to be looked after and seen that there aren't any complications to that. And they can come into the hospital with the urinary catheter, for example, and we need to know what has been done with it, how long has it been sitting, when do we need to change it and everything. So this area is something that actually involves all kind of care, which is also something that we have seen as an important part of standardizing, because we know that this will have a lot of effect on several levels of care, not just for one specific subspecialty, for example. It's mainly been driven by nurses, I would say, because this is very much something that nurses work with every day. So the goal there has been several goals, but it has been to increase patient safety during care transfers, that we know what kind of tubes or drains the patient has, when have they been inserted, when have they been inspected the last time, what kind of medications have they been given in those tubes or drains. And as it looks in, at least in most of our systems today, we do a lot of double documentation of this information, because we cannot transfer the information because it is structured in different ways. Which also, of course, leads to diminished administrative stress for care personnel, and improved quality of documentation when you can actually do it quite fast, instead of having to write it in different places. And just being able to also increase semantic interoperability between our systems. As I said, we have a lot of new systems coming, also a new AHR system. So how have we been working with this? We have had a regional group for standardization. I think all of us in that group are nurses. And we have been taking in experts in different care, for example, stoma care, for those kinds of, it's not really even tube or drain, but let's just say, for example, that, or intubated patients. We've had experts looking at what needs to be documented about those tubes, for example. We have also been looking at the requirements, both from the clinical perspective, but also what is expected by the national regulations, for example, to be in the patient journals. We've been looking at different stakeholders who need this information. What do we need to use it for? So both primary documentation and secondary use of the information. And of course, we've been looking all the time at the national regional clinical guidelines. And we've also done different workflow and concept analysis depending on the types of tubes and drains. So, and I must say that this has taken years. It's not been a small project. All of us have been working with other things, and this has just been a small project on the side. But it has taken a long time. But what we have come up with is a complete standard for documentation. It's both just the materials, for example, for the different tubes and drains that they've been inserted, where in the patient exactly they are. And then we also have the care itself of these tubes and drains and catheters. So what kind of interventions are planned? What kind of interventions are carried out? What are the results of those? and when, of course, they are extracted as well from the patient. And today we have implemented it in 2 systems in our main EHR that we will be phasing out, and then in our regional PDMS system. And there's also, between these 2 systems, we have a partial transfer between the information from the PDMS to the main EHR system at the moment. And it will be also implemented in our maternal care system. And there it will actually have the SNOMED CT codes embedded as well, which we don't have the possibility to do in our old systems, or in our old EHR at least. So it's just a very simple example. We previously had several ways to document. So the EHR system that we have today, it's 30 years old. It's been built upon all the time, and there have been different stakeholders, different people have wanted things in different ways, and there has been a regional governance of the terminology, but still, it's a lot of information that we have in an EHR. So and there hasn't been anyone that can actually say that this is exactly how we should document it. So for example, we've had all of these different ways of documenting central venous lines. And now what we've come down to is that we have one concept that is used for that specific venous access, for example. We have the same in urinary catheters, for example. It's had different names depending on the specialty or the kinds of nutritional tubes, for example, nasogastric tube or ventricle tube or something like that. So now we've standardized that, and the naming is the same in both of these systems. Yes.
So coming to fluid balance now, a similar kind of documentation problems were also seen with the documentation of fluid balance in different systems, like the PDMS system and our EHR. They could use the same term to document different things, and in a similar way, there were different terms used within the same system to document the very same thing. So in order to come over that problem, we thought of to have a unified terminology in both the systems so that we can eliminate the ambiguity of interpreting how we understand these terms. But before we get started, I would like to give you a brief introduction to what fluid balance actually is. It's actually body's equilibrium between fluid input and output, and it has quite a close relationship to tubes, drains, and catheters because body can take in fluid via IVs, and body can also lose fluid via drains or catheters as well. But body have a natural system of losing fluid as well, like through feces or urination or like sweating. And it can have fluid loss via bleeding or vomiting as well. And it's one of the most commonly monitored, measured, and documented entity as well for across all patient care levels. And it involves a few key activities, actually, that generate clinical data that should be consistently documented within different patient board systems, so that for patient care and patient security as well. It includes like monitoring the fluid balance, ordering the fluid balance monitoring, and then measuring the fluid balance, leading to calculation of the total fluid intake and output, and then fluid balance assessment, and then with need maybe some interventions to balance this fluid. And from the activity from fluid balance assessment, one can come to the physiological status of the patient as well. It could either be the desired neutral fluid balance where the input and output are the same, but if the input is more than output, it could lead to positive fluid balance, and patient can come with symptoms like edema. That is the most common symptom that one can face. And if the fluid output is more than fluid input, then with dehydration. So now coming to the main work that we have done across. So our deliverables included a conceptual model, SNOMED mapping, and then term level implementation, that means that it was interface level terminology implementation that we have come to those two systems. Coming to the conceptual model, sorry, it's in Swedish, so I will try to walk through it a bit fast. So the first part you see over here, we see the processes or the attributes associated with fluid balance, for example, that it is documented in a information system, and it could be measured in different units, for example, milliliter per day or milliliter per kilo per day, depending on the weight of the patient. And then coming to the central activity part, where the actual clinical documentation or the data is generated that leads to the documentation, like ordering, patient monitoring, calculation, fluid balance, and with need intervening for the fluid, for the neutral fluid balance. And then this part just shows the different ways the body can take in and take out fluids. For example, it could be the natural way, urination, feces, or sweating, the body can lose fluid, and the similar way they can take in fluid, or a natural ways like through IVs and drains and catheters, we can take in the fluid as well through different routes. So now comes the SNOMED part. We wanted to have semantic interoperability between those different systems, and we did the SNOMED mapping manually with in an Excel format. We just came to know from Anna just a moment ago that we can use for the version handling Snap to SNOMED as well. So we will look into that. And it was just a simple color coding for that mapping. Where red means that we couldn't find either no SNOMED term at all, or either the Swedish synonyms were missing in the Swedish edition. Yellow was like it was present, but maybe in some local extension of SNOMED, and green was a perfect match. And here I must mention that it was almost 85% that we could find already in the SNOMED. It was either the synonyms or like it was present somewhere else that needs to be propagated to our NRC. And it's just like a snapshot of how it looked. Like the red one lacked Swedish translation today, and the yellow one was just present in the Norwegian extension. And here is like just an overview over how it looks today after the implementation. Like it's a unanimous term level implementation. So the same Swedish terms that we found in SNOMED are now implemented within the system as well. And that was all from us. Thank you for listening.
Can I just say one more thing before questions?
Of course. Yeah.
What we have, basically why we're showing fluid balance is because that's the one that we have done the SNOMED mapping with, or some terminology binding. And we have not really come all the way with our tube strains and catheters, because we've also been waiting for the national work to be done. So we know how their concept models and information models look like, so that we can reuse that and not come up with our own, save some resources there and use the nationally accepted model instead.
Yeah, that makes sense. So thank you very much, Henna and Mahreen. I was just looking if there was any questions online, and I can't see any. We have time for questions? So if there's anyone in the room who has a question, please let us know. Yes. And you also have, yeah, we have a couple.
Hi. It's on, sorry. I'm a colleague of Henna and Mahreen, but I also have been working as a nurse. So I was a bit curious about the fluid balance you already implemented. It has been used in the system live.
Yes.
What was the reactions from the personnel?
Well, let's put it this way. We haven't gotten any negative. I mean, basically, it's been very quiet, which means that it's positive. We seldom hear anything that is positive, but we haven't had any negative. And we've had I must say that in our EHR, we have had a previous version of fluid balance. So their way of working has not really changed that much, but we have conformed into the new terms instead of, I mean, basically, if you have a way of documenting thorax strains, for example, you need to have the same naming standard in the fluid balance as well. So that's why we've changed it. But the way of working for them has not changed that much. But I would say that the most difficult part of all of this is to actually reach out to all of the people that are going to be using it. The one positive thing that we have, at least if I speak from a Karolinska perspective now, is that we have centralized EHR like notations, notes for nurses, and we also have a centralized way of writing in all of these tubes, drains, and catheters. So no one can go in and change how they want to document. It's the same for everyone, and we change that centrally. So they haven't really had a choice not to do it, which is also good because we know that if there are 5 ways to do it, you will be used. And it is used also for a lot of statistics. So we use that for improving our care as well.
There was a question up here first, in Elizabeth. Yeah.
Thank you very much. Regarding the devices, as you explained that you have the studies your possibility to stock in the electronic health record, do you imagine it could be used for some devices for traceability, for example, or for pharmacovigilance purpose? Or it's out of scope?
Could you give an example? I'm not sure that I really...
Because right now it's only for catheter and so on.
Yes.
But I'm just wondering if this kind of way of thinking the stocking information would be useful, for example, because sometimes patients could have some devices that are implanted.
Yes.
And it will be in pharmacovigilance purpose, really very helpful to have a quick way to find and patients who could perhaps have the medical device for which I'm thinking, for example, of the breast
implants.
Yeah. And but right now it's not the scope on which you have worked, but could be perhaps.
I think it could absolutely. However, I think that there is a lot more like rules, regulations on how you should document those and what kind of information you need to have. So in that sense, I think it would be easier to maybe, like, for example, for some, I think it's in operations, you can scan the kind of medical devices that you're using, which is also a dream that we would want to incorporate, that you can just scan the kind of catheter that you want to put in, and then it would just be sucked into the EHR with all the information about the sizes and length and whatever. But I think like the conceptual model as such, yes, you could use the same idea, but maybe you could actually pre-populate it in a different way with the regulations that are in place. That's just a guess. I don't know if somebody has another idea.
Sounds like a new project is being developed here.
Exactly.
So we have one down there. Thank you.
Hi, thanks for the great presentation. I'm encouraged to see that you're actually looking at other extensions for missing content. and requesting promotion. Can you talk a little bit about the process that you're using to look at the other extensions and how broad that search is?
Yeah, we are going to the all editions and browsing over there. And then if you find something that is not present in the international, the Swedish, then we just take it to the NRC, and there is like a whole process over there that we follow. So if that's the answer to your question.
Yeah, I think we could also mention that we haven't really come to the point where we're looking at the SNOMED codes in detail for the actual tube strains and catheters, because we've been waiting for the national. Yeah. But also we've done a bit of searching, and the concepts in SNOMED CT are usually quite good. However, there is a problem with the Swedish translations, which confuses us a lot because we don't really know. There are certain synonyms and words are used incorrectly, so that we have quite a lot to do with the NRC together with them. We're looking at we have them in the audience together to actually look through all the translations, because they're hindering us at the moment in our work. But also, at least for the fluid balance, we've also seen that we've been able to use the way that it's been modeled, or the concepts that have been used in SNOMED in our work to in our concept model as well. So those have been quite good translations. So it goes both ways.
Thank you very much. So, and yes, and there was definitely positives. And another positive is that now is the time for the networking. So now there's room and time for you, Swedish crowd, to go out and make further arrangements. Okay, so this concludes this block of sessions for today. And I want to thank you, Henna and Mahreen, for your excellent presentation. To online delegates, please join us tomorrow at 6:45 UTC. So 6:45 UTC, and that is 8:45 local time, for the James Reed Memorial Lecture. On-site delegates, now the networking reception is open, and it takes place in the exhibition hall. Thank you very much.